So hello, everyone. It's my pleasure to introduce today's speaker, Dr. Rishi Desai. He's an assistant professor of medicine at Harvard Medical School, and he's also an associate epidemiologist in the division of pharmacoepi and pharmacoeconomics at Brigham and Women's Hospital. His research focuses on generating high-quality evidence for comparative safety and effectiveness studies, mostly chronic diseases such as in patients with rheumatoid arthritis and in cardiology. He also has some interest in looking at underrepresented populations in clinical trials, including pregnant women, the elderly, and patients with multiple chronic conditions. And finally, as you can see from the title of this talk, he also has a special interest in applied methodological research at improving confounding control in observational studies. So I'm thrilled to have Rishi here. He has a great paper that I always sent to my students that was published in the BMJ on these different methods, and I believe his talk is based on this. So I'll let him say more about this, but it's a great read, and it's a great introduction to PS weighting methods. So thank you, Rishi, and glad for you to be here. Thank you. Go ahead.
Great, thank you for that very kind introduction, and Dr. Azule. And I'm thrilled to be here because over the years we have read really excellent work that's coming out of CNODES and followed it very closely. So I'm very excited to be among a community of highly regarded researchers. And hopefully this talk will serve as a gentle introduction to some of the newer weighting methods. And I'm always eager to hear people's feedback or thoughts on it towards the end. So this is just a disclosure slide. I just want to say that most of my current research is funded by the FDA through the Sentinel Innovation Center, as well as through various National Institute of Health agencies. I have in the past worked with pharmaceutical companies on some collaborative projects, but the content of the talk today is entirely based on unfunded research by any of these entities. It's mostly funded through the internal sources. So let's get that out of the way. And this is just an outline for this talk today. So I will go into some basic details around confounding and propensity scores, just basic information, probably a review for most of you, but just wanted to make sure we are all on the same page before we dive into some of these more complex topics involving propensity scores. So after doing that, I'll describe propensity score weighting more generally with some basic principles, and then dive deeper into various sort of advances in propensity score weighting approaches over the last decade or so, and hopefully will provide some sort of thoughts on how you can decide to pick among many available alternatives that I'll describe throughout the course of this talk. And finally, I will describe a case example to hopefully bring these concepts together and make them more tangible for the audience. And we'll end with a summary slide, just again, general thoughts on how to approach various weighting methods, propensity score-based weighting methods for your empirical example. As Dr. Azule mentioned, this almost entirely is based on our paper that I co-wrote with Dr. Jessica Franklin in the BMJ a couple of years ago. And so you can always access the full text copy on the BMJ website. So nothing that I'm talking about is new in that regard. Okay, so let's begin with some basic concepts around confounding and why we worry about this so much, and why we like propensity scores and why we use them all the time. So when we talk about sources of errors in observational studies, so observational studies are non-randomized studies of medication use that we all conduct all the time to study drug effects outside of clinical trials, we worry about a couple of sources of biases, right? So there's random error, which is always there, and hopefully it becomes a non-issue as your sample size increases, because that's how random errors work. But the thing that gives us sleepless night as epi researchers is the systematic sources of biases, and we generally bucket them into the three broad categories. So first being selection bias. And I think of selection bias as something that you did to arrive at your study population was problematic, or how you retain participants in your study is introducing some sort of bias. So you can think of a study where participants self-selected in a survey or something where they reported drug use, and then you look for outcome in this population, then that may raise a flag of selection bias because these participants self-selected themselves into your study. And so that's the kind of thing we are talking about when we mention selection bias. Then there's information bias, which is fairly straightforward to conceptualize. It's basically measurement error, which is always there because most of the times we are working with data sources that collect data for a different purpose, like administrative claims, for example, insurance claims. And so you have pretty much many of your variables that are not perfectly measured, like disease activity for rheumatoid arthritis, for example, is not well measured in any of the sources that we routinely use. And so you come up with these makeshift endpoints or variables that hopefully will do a decent enough job of representing some of these concepts that are not directly captured. But you have to keep in mind that this is introducing a source of bias, generally categorized as information bias or measurement error in your study. The third bucket, I think, is where we are focused on today, is confounding bias. So confounding bias is something that occurs in your study, a distortion between the exposure of interest and outcome of interest due to a third variable or more variables, but not the focus of your study, the extraneous variables, the nuisance variables that you want to account for. And so confounding bias is something that we always worry about, but thankfully it is largely addressable through methodological advances and advances in measurement of some of these variables. And I have this sort of the right side of this figure in red boxes because I wanted to convey the point that propensity score methods are only sort of accounting for or helping you with sort of this side of sources of errors in observational studies. So propensity scores are good for addressing confounding bias, but not the other sources of biases. So talking a little bit more about the confounding issue. So confounding, this is the classic confounding triangle. So confounders are variables that are simultaneously impacting the treatment choice. So age being a classic confounding variable example where you are likely to make a different treatment choice for patients who are older versus younger, and age is also risk factor for many outcomes of interest like mortality. And so age here is a classic confounding variable that is the kind of thing that we worry about in our studies. So when you condition on the propensity score, so propensity scores, as some have described them, are balancing scores. So you force the distribution of these confounding variables to be exactly similar or somewhat similar to between the exposure group of interest and a reference exposure group. And so the propensity scores act on the left side of the confounding triangle and basically break the confounding triangle to provide you with a population where you are now able to make somewhat reliable inferences based on conditioning on the propensity score. So just wanted to highlight this point that propensity scores act by sort of breaking this link between the confounding variables of interest and the exposure of interest. Just one more slide before we move forward. So this is again from this nice paper by Sebastian Schneeweiss, Taxonomy of Confounding. And basically, even when you talk about confounding, there are basically two buckets. So measured confounding and unmeasured confounding. And when you have measured confounding, you feel somewhat at ease because you are able to then account for these variables or differences in these variables through design or analysis. And the other side of this equation is the unmeasured confounding. And unmeasured confounding gives you more worry because you are not sure how to deal with that most of the time. So here I just wanted to make a point that propensity score methods, most cases, are only amenable or are only addressing the measured side of confounding and not unmeasured confounding in most cases. There are some arguments or some methodological advances that have occurred over the last 10 years or so, where people have used these proxy adjustment approaches, whereby basically if you measure a lot of variables through routinely collected healthcare data and throw them all into your adjustment method, you hope that some of them are associated with the unmeasured confounding, and you are proxy adjusting for these unmeasured confounding. But by and large, propensity score methods are only accounting for measured confounding. And so through this series of figures, the point I wanted to make here is that propensity scores are great and we use them all the time, but they're only accounting for or addressing a relatively small portion of the sources of errors or bias that can impact your study. So if you shouldn't take this for granted, because even if your propensity scores are perfectly executed, your study may not be perfect because it may be impacted by the other sources like selection bias or information bias, for example, or unmeasured confounding. And so that's just the general point I wanted to make to make sure that we are all on the same page with respect to expectations for the propensity score analysis. Okay, so moving on to just what, why, and how of propensity scores. So propensity scores are basically probabilities, conditional probabilities of receiving a particular treatment versus no treatment, or treatment versus a reference treatment, conditional on patients' covariate constellations. So for example, probability of treatment given patient's age, gender, comorbid conditions like diabetes, hypertension, etc. Because it's a probability function, the range is between 0 and 1, and the obvious thing to say here is that the score depends on what you measure, because that goes into the right side of the equation. And so it's largely dependent on the measured characteristics, and that's why it only accounts for measured confounding. The reason why propensity scores have been so popular over the last couple of decades is that they are a really useful tool for efficient confounding adjustment, right? So when you are thinking about treatment outcome studies in observational data, you are generally concerned about confounding by many factors at the same time. And so what propensity scores do really nicely is that they combine all this information into this single scalar variable, and by accounting for that, by matching on it, for example, you are now able to efficiently address all these important factors that you are worried about at the same time. And so that's really the basic appeal of propensity score. You only, once you construct a score, you only need to worry about accounting for that score. And so it's a really useful, efficient method for confounding adjustment, and that's why it has become really the mainstay of confounding adjustment in observational studies, at least in the pharmacoepidemiology field, over the last couple of decades. And how to build a propensity? So again, it's a very, very straightforward method. It's basically so you can go out and build models through different modeling approaches, but the most common one is a logistic regression model that includes treatment as your left-hand side variable, or treatment as the outcome variable, and all the measured patient characteristics as your right-hand side or independent variables. You can use advanced approaches, including some machine learning approaches as well, but by and large, logistic regression has remained the most popular, most widely used approach to model propensity scores. And really what you're doing with this process is that by using the model, you are trying to mimic the decision-making process of a physician given the patient he or she is seeing in front of them, by looking at all their covariates or all their characteristics, they make a choice of treating versus not treating, or treating patients with alternative treatments. And that's the sort of the basic concept you're trying to get at with modeling these scores and creating a probability value. So this is a really quick review of propensity score methods. Is probably things that you already knew, but just wanted to make sure we are all on the same page. So just some basic information. Now, moving on to some general concepts of the theme of today's talk, which is propensity score weighting. So once you have propensity score calculated, there are several approaches that you can use to account for that score, and by accounting for score, by accounting for confounding variables. And these are generally classified into 4 broad buckets. So matching is the first one, which is probably the most popular one even today, and most intuitive to consider, because it's just once you find someone who has equal or close enough propensity score, you are just matching 1 to 1 or 1 to many people with based on this one score, and then be done with it. You can run your analysis in this match sample and be happy that you accounted for all the measured confounding through that. So it's a really intuitive, very simple approach, matching. There is also regression adjustment, which is again one of the simpler approaches, where you throw in the continuous propensity score value, the probability value between 0 and 1, either by itself or through some accounting for non-linearity, like splines, for example, things like that, and basically create a simple outcome model to account for all the measured confounding through this one scalar score. So regression adjustment is again a simpler approach. Stratification is also fairly straightforward, where you create bins of patients with propensity score in certain ranges. 5 or 10 strata are the most commonly used one, or at least in the past. And then the treatment effect is computed within each of these strata, and then eventually you combine the treatment effect through some sort of a weighted average across the 5 strata. And the final approach is weighting, which is what I'm focusing on for today's talk. So basically, weighting is a more flexible approach. It uses the score itself to calculate weights, which basically create a pseudo population in which you break this link between the confounding variables and the exposure assignment. So basically, by forcing the distribution of confounding variables to be similar between the exposure and the referent exposure of interest and the referent exposure, you are breaking this link in the pseudo population, and hence accounting for confounding. I should mention that although there have been incremental advances in implementation of propensity scores over the last few decades, but most methods that you see, most novel methods, they fall into one of these 4 broad buckets, and these 4 broad buckets were described already in 1983 in this Rubin Rosenbaum paper that we cite all the time. So there have been incremental advances, but not sort of advances in the fundamentals of using propensity scores. Okay, so you might ask how these approaches fare against each other on various domains. So this is just a basic table, probably too simplistic, but I think serves the purpose for today. So I have in columns matching, stratification. I say traditional because one of the approaches that we are talking about today is fine stratification, sort of more recent advances in using stratification. And then we have regression and we have weighting. And there are 4 rows denoting various concepts. So let's begin with bias. This is a basic job of a propensity score. And I think under most circumstances, all of these methods achieve this. I think bias is the basic job of a propensity score. And as long as you ensure that the score is modeled appropriately and all the outcome risk factors are included in this score, or to a reasonable extent, I think in non-exceptional circumstances, all of these methods in most circumstances achieve the goal of bias adjustment. So to me, I don't think bias is a parameter that drives me to pick one approach over another, especially when your sample size is large enough and you have some reasonable confidence around the score that you bring. And this has been shown repeatedly, I think first in this classic paper by Stromer et al. In American Journal of Epidemiology in 2005 already, that these approaches likely perform similarly in most unusual circumstances. Precision, however, is a different story, right? So precision has to do with how tight your confidence limits are or how small your standard errors are. And one method out of these four is notoriously bad at this. So matching, in particular, one-to-one matching is problematic here, because if you have a really large sample, let's say 100,000 patients, only 5% of them are exposed, let's say 5,000 patients. You do one-to-one matching and you match all 5,000 patients out of remaining 95,000 patients, you still end up with 10,000 patients as your match sample, and you are discarding information on 90,000 patients, which many of which are probably matchable, but just not matched because you enforce this somewhat arbitrary cutoff of one-to-one. And so, in general, I think across the four methods that I described earlier, matching would fare somewhat worse in terms of precision. And this is the kind of thing that we care about a lot when we are doing many pharmacoepidemiologic studies, because we are oftentimes dealing with rare outcomes, and you want to maximize your precision. There is no point of generating a non-biased result if the precision is not there, because ultimately you are going to end up in a situation where you may not have too much confidence in the results because of wide confidence limits or high standard errors. So matching, I think, overall widely accepted that it does the worst in terms of precision across the four methods. There is also an important aspect, which is transparent reporting of balance, evaluation of balance and reporting. So is your propensity score doing the job that it's intended to do? The basic parameter of evaluation of balance. And there are some methods that are good at it. So I think one-to-one matching is really popular, because for clinicians or for audiences that are not very familiar with various pharmacoepidemiologic approaches, I think one-to-one is inherently appealing, because it's like a trial, looking at the trial table one, right? So you are able to report balance in most patient characteristics in a one-to-one match sample if you use matching. However, if you use stratification in the traditional sense, this is possible, but it's very tedious. You have to report 5 table ones, because the basic concept of stratification is you are achieving balance or trying to achieve balance within these bins. So 5 or 10 bins, so you end up reporting 5 or 10 table ones, which is not very efficient. Regression, again, you cannot transparently report achievement of balance. You just throw this score in the model and hope that it's doing its job well, but it's unclear how the balance is achieved after that. Weighting, on the other hand, is similar to one-to-one matching, because although it's not, you are likely to end up with different ends in the pseudo population compared to the original population because of weighting. You are still able to show that the balance was achieved by on a means and a proportion scale by following the traditional table one type reporting metric. So I think weighting and propensity score matching do quite well in terms of reporting balance. The last point, I think, is a really appealing one for me, because there is flexibility in the target. So we will talk about target in next couple of slides, but I think of the 4 methods, only weighting allows you to target your estimand to desirable population of interest. So in matching, there is no option. The target of interest there is the average treatment effect in the matchable or matched population. You have no control over how what type of people you are able to match. It's just what you end up with. Stratification, again, similar. There's no clear estimate there. Regression, similar story. But weighting, because it is flexible, because there are multiple options available, weighting does a decent job of allowing the researchers to target their treatment effect to a specific estimate or target of inference. And we'll talk about our target of inference next. But overall, I think when I think about these different approaches, because weighting is flexible in terms of implementation, because there are multiple options available, I think of weighting as the most appealing option for a variety of reasons. And I think a lot of researchers share this enthusiasm, especially over the last 5 years or so, where weighting approaches have become quite popular. Okay, so moving on to the target of inference. So I think a lot of our paper is based on this concept. So I thought it is very important to go into some detail of what we mean by target of inference or estimand. So basically, when we talk about target of inference, we talk about the patient population to which the estimated treatment effect applies. And this probably is not very clear with this definition, but if you think about it from an empirical standpoint, I think a key question that could help there is would it be feasible to treat all the eligible population that you are considering with the treatment of interest? Is just a simple question. If you ask that question, and if the answer to that question is yes, then it's reasonable to target the average treatment effect in the whole population, or ATE, as you may sometime have come across. To make it more tangible, if you think about a chronic disease like atrial fibrillation, where there is a new treatment, which is basically an alternative to an old treatment, for example, dabigatran versus warfarin, barring certain contraindications, these are basically exchangeable treatments. And so in this case, everybody in your study population basically is eligible to receive either warfarin or dabigatran. So in that case, it is fair to target your inference to an ATE, or average treatment effect, in the whole population. On the other hand, if the answer to this question is no, only patients with certain characteristics who actually end up receiving the treatment are ideal candidates or eligible to receive the treatment, then you may be better off targeting the ATT, which is the average treatment effect among the treated population. And if you think about a specific example, I was involved in this study of antipsychotic medications and their teratogenicity after exposure in pregnancy. So if you think about this population, there are probably many patients, many women with psychiatric issues during their pregnancy, but not all of them are ideal candidates for treatments, because the treatment risk-benefit profile at that stage, at least, was unknown. So not everybody who has a diagnosis of psychiatric illness or may have an underlying psychiatric illness may not be considered for treatment. However, if the illness is bad enough that the physicians determine that they are really severe enough to require treatment, then patient population with certain characteristics, namely patient populations with higher disease activity or more recent episodes of psychiatric illnesses, may be considered for treatment. And in this case, I think it's probably useful to target an ATT, because not entire population of pregnant women who have a history of psychiatric illness are eligible for treatment. And so this is really a handy way to think about ATT versus ATE. We have found this to be quite useful. There are a couple of additional points that I wanted to make. So there will be circumstances in which the treatment estimate of interest would be among a population with clinical equipoise. So if you think about the dabigatran warfarin example, there may be some outcomes for which it's always clear that certain patients are always good candidates for only dabigatran, certain patients are always good candidates for only warfarin. But there is a subset in between where the trade-offs are not known, and these patients are eligible for both of these treatments. And I guess the sophisticated term for this is having clinical equipoise in this population. And so there are circumstances where you want to target your inference to a patient population with clinical equipoise, and there are approaches, there are weighting approaches that allow you to do that. And so I just wanted to make this point. Finally, before we move on, I think the last point I wanted to make is that the distinction between ATT, and ATE is only relevant if there is some level of treatment effect heterogeneity. If there is no treatment effect heterogeneity by single patient characteristics or some patient characteristics in combination, then ATT and ATE will always coincide, and this sort of distinction becomes moot. I would also want to note here that in randomized controlled trial, the target of inference is ATE, which is also the ATT because it's the same population that you draw your inference on. But this becomes really a useful distinction for observational studies because the questions are somewhat more nuanced in observational studies. So maybe a really dense slide, but I think this is a really important concept to consider when we select among best or alternative treatment or alternative weighting approaches. So I wanted to sort of spend some time describing this. Now, okay, so moving on to really the meat of this presentation, which is how do you go about selecting the best option among alternatives? So we outline a stepwise process in our paper. So as you can see, the weighting approaches don't appear until the very last step. So I wanted to sort of go over the first few steps, which I think are really useful to think about even before considering using weighting for your study. So the first step, I think, is the obvious one, where you have to correctly specify your propensity score model. I think this becomes really important for weighting approaches, some weighting approaches, because we are using the weights to create pseudo populations, unlike matching, where you are not using actually the propensity score, only the rank matters, not the actual value matters. So misspecification is a bigger issue for some of the weighting approaches, and we'll talk about that in a minute as well. But just wanted to mention this here. And misspecification takes multiple forms. There are misspecification due to missing covariates. There are misspecification due to missing interactions in the propensity score model, or incorrectly specified functional forms, for example. But a simple approach of checking covariate balance provides reassurance against gross model misspecification. So if you are able to achieve balance, I think it's a good indicator that your propensity score model is perhaps sufficiently specified. And in theory, there are some models, alternative models than logistic regression, like random forest, for example, or boosting, that could handle modeling of propensity score better, may have less misspecification in theory, because these models are adept at handling nonlinearity as well as including interactions without pre-specifying them. However, when they have been tried in methodological research, so for example, this 2008 classic paper by Soko Setoguchi, it has generally resulted in similar performance to logistic regression. So just wanted to mention this. So propensity score model specification is important when considering weighting, because sometimes you're using the score itself to sort of calculate this pseudo population. So it is important. The second step then is, so once you have the correctly specified propensity score model, the second step is to look at the overlap. It's really important to do this for several reasons, as we will talk about. So sufficient overlap, I have it in quotes here because I think this is subjective for most cases. This is a cartoon at the bottom that we use for one of our courses, but this is not based on real data. It's just to convey concepts, and reality is not always as sort of simple as this one. But nevertheless, it's useful to think about this from these toy examples, where you have situation A, where distributions are largely non-overlapping. There is extensive treatment selection. Some people always get the red treatment versus some people always get the blue treatment. B is there is moderate treatment selection. There is some people where there is equipoise, but sometimes but most of the times the treatments are selected. C is the best scenario, where there's little clinical equipoise or little preference for treatment. And so what we suggest is to basically implement a non-overlap trimming. So doing so will get rid of a certain proportion of your population. So in A, you'd probably lose 80 to 90% of your population. In B, you'd probably lose 50%. In C, you probably lose 5 to 10%. So in addition to providing you with the best population in which you can reliably make inference, I think this also serves as a really nice diagnostic. So if you lose a lot of patients after this non-overlap trimming, it's probably an indicator that you need to reconsider. So when you have this situation of insufficient overlap, what we recommend is basically design modifications. So you can consider alternative comparison groups, for example, and try to get to a situation that is closer to C in this example. And if you are not able to do that, even with the design modification, that you need to be asking yourself whether if this is a clinical question that can be answered with the data that you have at hand. Maybe it's the case that's the population that you want to target, but again, it's a cautionary note if you lose a lot of patients after this non-overlap trimming. If you don't, however, if you achieve sufficient overlap, which is subjectively defined, then you go on to this next step of choosing among alternative weights. And here, the concept that I was talking about, ATT, ATE, and average treatment effect in a subset with clinical equipoise comes in handy. Because if you know at the study outset what you are targeting, then it's easy to pick, right? So if you're targeting an ATE, there are basically two options. So IPTW, inverse probability treatment weights, probably the most commonly used weighting method with propensity score, or fine stratification weights that target the ATE. So these become your two options basically among alternatives. Similarly, if you have ATT, then you can try SMRW, or standardized mortality ratio weighting, sometimes known as weighting by the odds, or fine stratification weights that target the ATT. And if you are targeting your estimate to a population with a clinical equipoise, then the newer methods like the matching weights or overlap weights may be your choice of method. So let's briefly talk about each of these methods. So IPTW, again, they are by far the most commonly used weighting approaches. It's really intuitive, right? So calculation is on the right-hand corner here. Basically, it's the inverse of your probability of actually receiving the treatment. So for treated populations, 1 over the PS. For untreated is 1 over 1 minus the PS, or the complement of it. So there are some appealing features to this. It's very simple, very intuitive. The target of inference is clear. It's always targeting the ATE, average treatment effect, in the whole population. It is also easily extendable to more than 2 treatment options. I think this is one of the real advantages here, that you are able to accommodate more than 2 treatments. And then they are also by far the most commonly, or actually at this point, the only weighting approach that is that has theoretical basis for use in non-point treatment setting, meaning time varying settings. So IPTW is the most commonly, or the only available at this point in time for time varying treatment weights. However, there are some cautions with this approach, which are also well known. So this score is directly used by inverting it to create the pseudo population, and so unstable weights are very common, because the scores that are close to 0 for the treated group and close to 1 for the untreated group are likely to result in large weights, basically atypical patient populations or patient groups dominating your analysis through this large weights. And there are approaches to get around this, weight truncation, for example, or trimming. But when talking about IPTW, this is always something that comes up, and always something I should keep in mind, that unstable weights are a real problem. The performance also has been noted to be generally less robust in situation of misspecification, and this is noted in a couple of papers that I cite here. And this is intuitive as well, because you're using the score directly to sort of basically create this make-believe world where propensity score directly informs how many sort of copies of each person is contributing to your analysis. And if that score is faulty through misspecification, that is likely to compromise performance in this case. And other than getting or fixing the specification, I don't think there are any remedies to this problem. So just something to keep in mind when you're using the IPTW. There is the fine stratification weights that can target the ATE. And at this point, I guess I should mention that I led the paper that described the fine stratification weight here in 2017. So I have, I guess, an intellectual conflict of interest here, but this is my favorite method of weighting because of several properties that I'll describe in a minute. But so basic concept is doing stratification on a finer level. So for example, rather than using 5 or 10 strata, we use 50 or 100. And we recommend using the creation of the strata based on the distribution in the exposed population. This ensure efficient allotment of exposed patients in each of your strata. And then once you have the strata defined based on the distribution in the exposed patients, you basically place your unexposed patients based on their propensity score into one of these fine strata. So this is the stratification step. The next step is weighting. So when you use the weighting based on the calculations that are described here, this is basically weighting by the overall population in each strata. And when you do that, you basically reshuffle the balance of exposed and referent patients here in the weighted sample, and by doing so you achieve balance and in a way that is reflective of the overall population, and hence this approach targets the ATE. There are some really unique features of this method that we like a lot here. So target of inference is clear. In this case, it is ATE. I'll describe the ATT in a minute. But I think the second point here is really appealing to us because it's almost a semi-parametric implementation of propensity score weighting, right? Because you're only using the propensity score to create the strata. You don't use the score themselves to calculate the weights. You use the number of people based on the strata that you have defined based on the propensity score to create weights. And this is really appealing because this makes this method theoretically very robust against misspecification, similar to matching. Only the ranks matter, not the actual values of the propensity score. So I think there are many theoretical advantages to this approach, and that's why we have come to use this a fair bit in our recent experience. Extreme weights are less common, again, because you're not using the score itself, you are using the number of people to weight. However, there are certain drawbacks for sure here as well. It does not readily extend to more than 2 treatments. We have worked in this a fair bit, and what we have observed is that you quickly run into sparse data because you are stratifying simultaneously if you have more than 2 treatment groups on those multiple propensity scores, which is again inefficient. And then even in 2 treatment setting, if your strata are sparse, there may be situation where weights are extreme and you may need to consider some form of truncation. While talking about the fine stratification weight, let's also cover the ATT, the weights that target the ATT. So basically here, the treated population gets the weight of 1, and the untreated population is weighted based on the number of treated patients within each data. So you follow the same procedure for stratification, number of data based on the PS distribution in the exposed, and then reference based on their PS. But now when you weight, you will basically redistribute the unexposed population in a way that will equalize the number of unexposed within each of these data. So you can think of this as M2N matching, basically, after weighting. Again, pros and cons are very similar, so I am not going to go into detail. But again, the only point I want to make here is that the fine stratification-based weighting is flexible, that it can target ATT as well as ATE. The other simple approach to target ATT is SMRW, weighting by the odds. So all the treated get weight of 1, untreated are weighted based on the odds, that's PS over 1 minus PS. Pros and cons are actually very similar to IPTW, because again, here you are using the propensity score to create weight. So in theory, this is more prone to misspecified propensity scores, or problematic in situations of misspecified propensity scores. However, on the plus side, it is also readily extendable to more than 2 treatment options. So again, pluses and minuses. And I think, as I mentioned before, in many general cases, all the approaches would do similarly well. Finally, moving on to some of the more recent advances. So this is the matching weights, which allows you to target average treatment effect in a subset of patient population. So if you look at the calculations, it's similar. The denominator is identical to the IPTW, but in the numerator, what you have is the minimum of the 2 propensity score. And this is a really clever adjustment by which you basically ensure that the distribution of the weight, it's between 0 and 1. So extreme weights are impossible by design. And in terms of the cautions here is that the target is variable. When you have only 2 groups and one of them is considerably smaller, it's likely closer to an ATT in that smaller group. And again, you cannot do much about what you're targeting, unlike the previous approaches. Here you work with what you get in terms of target of inference. And in situations where there is limited overlap in the PS, this is likely providing you a population of inference which is unlike the ATE or ATT, which may be problematic in situations of treatment effect heterogeneity. Finally, this is perhaps the most recent weighting approach, which is the overlap weights becoming popular. Again, very clever design. You are weighting by the propensity score in the opposite group. So for the treated group, you are weighting them by just multiplying them with the probability of 1 minus PS. And for the untreated group, your reference group, you are weighting them by probability of receiving the treatment or the PS. And so again, by design, the scores are between 0 and 1. So less. So it's impossible to get extreme weights. It's also extendable for more than 2 treatment groups. Cons are very similar to matching weights. The target of inference is variable. It may lead to treatment effect estimation in a population that is not reflective of ATE or ATT. And a unique feature here is that if you use logistic regression, if you're only having 2 groups, then the overlap weights will actually yield exact balance. And that's just a quirk of how the logistic models calculate the scores. And if you use a different model, it's not going to be the case. But for logistic model, you're always going to end up with identical distribution, which is actually positive and negative. Negative because then you are unlikely to find out if the model is misspecified, because by design, it is giving you perfect balance. Okay, so that's a fairly quick overview of all the 6 approaches that we covered in our paper. I think with this case example, I wanted to show you how these work in practice. So this is basically a cohort study that we used previously of dabigatran versus warfarin in US commercial claims databases, classic new user active comparison design. We are following up for an effectiveness outcome of stroke. in this situation in patients with atrial fibrillation who initiate either dabigatran or warfarin. So that's a basic cohort. We calculated the propensity score based on 72 pre-specified covariates based on clinical knowledge. And this is how the PS distribution looks overall and with all these weighting approaches. So I just orient you to this figure. So the first one on the top left is the overall crude without weighting. So you can see there is some treatment selection going on with some people always being preferred with warfarin. So that's the first peak of warfarin, the blue peak. But once, and on the right, the top right is the crude distribution in the overall population. So on the left, what you also have is each weighting approach that targets the ATT or ATE in the subset population. So that's the fine stratification, SMRW, matching weight, or overlap weight. And as you can see here, in all these four approaches, the left peak for warfarin is gone, because they are underweighted or downweighted in all these approaches. And so you are able to match the distribution of the overall population as to the dabigatran distribution. And that's the concept behind the ATT, average treatment effect among the treated, which is the treatment being dabigatran here. But if you do an IPTW on the right, or fine stratification weight ATE, you are basically able to retain the whole population. And so both peaks of warfarin patients are represented in the weighted population. Again, this may be desirable, maybe not, depending on what you're trying to study, what you're trying to extend your inference to. But just something to keep in mind, that the population changes with the weighting approach. This is the distribution of weights. Again, on the left, you have the distribution of weight. There are some approaches that are bound between 0 and 1 by design. So for example, matching weight, overlap weight. As you can also see, most of our approaches have done well here, except for the IPTW, which is again not entirely unsurprising. This is truncated 99%. Still, you have weights ranging to 10, which is not that bad. But just to keep in mind that we had I think about 50 patients with weights around 500, which is not entirely unexpected if you're using IPTW. But if you're using any other approaches, basically this is not a big issue. Fine stratification weight, for example, they behave very well with highest range 5 to 6, as well as SMRW in this case behaved quite well as well. So again, just a useful diagnostic, always to check the weight distribution. This is the baseline characteristic tables. Again, I won't go into detail of this, but there are two groups, warfarin, dabigatran. This is the overall crude before weighting. This is the whole population. The basic point I wanted to make here is that if you look at the age distribution, it's older in warfarin treated patients, 71 versus 67, and giving the average in the whole population of 70. If you look at some approaches that target the ATE, right here, you end up with balanced population, but the average age looks very similar to the whole population. So that 70-70, it's close to whole population. If you target an ATT, the average age looks similar. You again achieve balance, but average age looks similar to the age in the dabigatran population. And for the ATE in the subset, the average age looks to be somewhere in between the ATT and ATE. Again, it is by design. You are targeting your inference to different population with these different weighting schemes. All of them achieve their objective of balance, but the distribution of covariates, distribution of patient characteristic is shifting across weighting approaches. Again, salient point to keep in mind when you use weighting. This is again standardized differences, basically showing that after weighting for most of the approaches, the standardized differences go close to 0, which again indicates that the weighting approaches are doing their job of achieving balance for most cases. There are IPTW, I think there are some away from the value of 0. But for most cases, I think the balance, at least when you compare them to the crude, which is the purple square, they are going close to zero, indicating that the weighting by propensity score is doing its job of achieving balance. Finally, the treatment effect estimates. So as you can see, the crude is 0.64. After adjusting for the 72 confounders, we are able to get these results closer to the null. It's interesting pattern. So overall, I would say that the estimates or conclusions would not differ based on which weighting scheme you used. However, it is actually very interesting to see that based on the target of inference, they are quite similar. So if you look at the approaches that target the ATT, the point estimates as well as the confidence intervals are very, very similar. So ATT fine stratification 0.79, SMRW 0.78. It's slightly different when you do ATE. They are similar with each other. So 0.73 and 0.73 between the fine stratification weight ATE and and IPTW, but they are slightly different from what you get if you're targeting ATT. Again, in both cases, you'd probably conclude that the effectiveness of dabigatran is somewhere between 20 to 25% range. But I think it's important to note that point estimates as well as confidence limits in some cases are different across approaches, but similar between approaches when you are looking at approaches that target the same population of interest. These are some of the recommended diagnostics that basically I was describing with this example. Let's not get into that too much. And this is my last slide. So basically, we think that weighting based on the propensity score is a really valuable tool for confounding adjustment and should be routinely considered over approaches like matching. And ideally, the selection of appropriate weighting approach is driven by the target of inference that you knew before you run your analysis, and you select on a pre-specified basis. This is specific to each study question, as I was trying to describe. And overall, I think my general sense is that when applied carefully and in most circumstances, all alternative approaches to confounding adjustment, that actually including or excluding propensity score, even the multivariable model, would do well. There are situations where performance will be different, so you need to be mindful of that. So for example, you're always worried about when outcomes are rare, you need to use methods that preserve your precision. So weighting probably would be a better approach there. But in general circumstances, I think design is the primary sort of consideration when you're looking to generate valid inference, and statistical methods, given that you have measured your variables well and you have measured most of them, is likely to perform similarly as we have seen across many examples from the past. So that is my last slide. I do want to plug in a couple of things. So there are macros available on our website for fine stratification. If you found that to be of interest, there are toy data sets that are available. I think easy to follow with the guide that we have provided. So feel free to use that. If you're an user, there are a couple of nice packages. Weighted is the one by Noah Greifer, who has implemented all of these weighting methods. I think there is a new iteration of the Match It package, which is also written by Noah and allows for implementation of all these weighting methods. So just some resources for you. Okay, so that's my 1 hour. I really appreciate the opportunity for being here, and happy to take questions if there is time. Here or on emails.
Thank you very much, Rishi, for your excellent talk. We may have time for 1 or 2 questions.
Yeah, Rishi, thank you very much. This is Sami here. So typically, I mean, this was an outstanding presentation of confounding in 1 hour and all of the weighting approaches for pharmacoepidemiology. I think that everyone here at CNODES will benefit tremendously. Thank you for this talk. So typically, the treated group is a much smaller group than the comparator drug.
Yeah.
Now, there are situations, and I've seen in some papers, where you have 15,000 patients who are using the treatment of interest, and only 2,000 are using the comparator. This is unusual to what we typically see. Any caveats to watch out for in these circumstances when we are dealing with all of these weighting methods and propensity scores?
Yeah, that is a great question, and we have actually seen this ourselves in one or two example cases. So in that case, if you use approaches that target the ATT, or if you use matching, you're basically able to match only 2,000 exposed patients, and not able to match if you match perfectly, not able to match a large proportion of your exposed patients, and your estimand basically becomes an ATC, average treatment effect, among the control population. So in that situation, I think if you can reasonably extend this to target an ATE, that's probably a better approach, an IPTW type approach, or stratification weights with target of ATE would probably be a better approach. But again, it differs based on the study question. But yeah, I think it's an unusual example, but not entirely unheard of.
Yeah. Okay. Thank you.
Yeah.
So maybe one question from me. So you showed very nicely that PS methods allow you to visualize the PS distributions between the groups, right? And trimming will hopefully allow you to compare groups that are more comparable. You get this clinical equipoise. But typically, if you don't intend to use PS methods, it's not something we would do. So my question for you is this: is there a case to be made that it would be good practice to always use PS methods to look at your PS distributions and even trim patients out of that are in the non-overlapping regions,
yeah,
even if PS is not meant to be used in your analysis?
I think that is a great point. I think I am a huge proponent of this type of thinking, that PS is not useful for only for the analysis, but I think it's also so the way you were describing it, I think it's also can be thought of as a design tool almost, where you try to come up with a study population based on the PS distribution, which is roughly comparable or with clinical equipoise. And I think a senior researcher, or many senior researchers I've worked with, have been a proponent of this as well. I think Bob Glynn comes to mind. He has, I think they've implemented this already in their 2005 AJE paper, where they show that based on just non-overlap trimming, even if you use just a multivariable logistic regression or whatever regression model in the trim population versus the overall population, you are likely getting closer to the truth, or at least more stable treatment effect estimate. There is also the case to be made for asymmetric trimming, right? So this was from Till Stummer's paper in AJE as well, and this is again an underused tool, I think, where you basically are based on the PS, based on the atypical PS, so really high PS among patients who end up not treated, and really low PS among patients who end up being treated. If you implement trimming in this section of the population, you are likely accounting for unmeasured confounding to some extent as well, regardless of what you do after, whether it be matching or weighting or regression or any other approach. So I really am in favor of using PS based methods as almost a design tool as opposed to, or in combination with analysis tool.
Okay, great. Thank you so much. So we're over our time, and this is fascinating. I think we could continue for another hour, but I think we're going to let you go. So once again, thank you so much for giving us a talk on, I think this is an emerging area in pharmacoepidemiology. I think we're going to see more of this. So thank you very much for your very clear talk.
Great. Thank you again for having me.
Thank you.
Bye.